Good afternoon and welcome to today's SAMHSA-sponsored webinar titled Connection in Crisis: The Impact of Peer Support, presented on behalf of the National Alliance on Mental Illness, also known as NAMI. Today's presentation will be recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. Closed captioning is available and can be viewed by clicking on the CC icon at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have an ASL interpreter who should be seen spotlit on your screen. During the presentation, please add your questions and comments into the chat box, and questions will be asked out loud for the presenters to answer at the end of the presentation. When the presentation ends, please take a few moments to complete a brief survey that will show in your browser as you exit the platform. Thank you again for joining us, and we will now begin today's presentation.
Good afternoon, everyone. I'm Terry Brister. I'm the Chief Program Officer at NAMI, the National Alliance on Mental Illness. And it's my privilege also to be able to welcome you to the webinar this afternoon. We're excited about our presenters and excited about the topic. And the learning objectives for today are to learn the value of peer support across the three pillars of crisis care: someone to talk to, someone to respond, and a safe place to go. Next, to learn how facilities and systems can engage peer support specialists in the continuum of crisis care for individuals with serious mental illness or serious emotional disturbances. And then finally, to understand how peer support services expand the options and workforce available to individuals with serious mental illness and serious emotional disturbances in crisis situations. And we have two wonderful presenters with us today. If you'll go to the next slide, please. All right, we have Dr. Amy Watson, who is a trained mental health services researcher. She's focused on the experiences of and interventions to reduce the involvement of people with serious mental illness in the criminal justice system. This has included research on police response to mental health crises, the Crisis Intervention Team Model, or CIT, mental health courts, and reentry programs. Her current work is focused on developing crisis response services that do not require law enforcement involvement. Dr. Watson recently served as president of the CIT International Board of Directors and is currently the president of the Board of Crisis Intervention Programs and Training. She's authored over 100 publications, and earlier in her career, she worked as a probation officer on a team that served clients with serious mental illness. Steve Miccio is our second presenter, and he's the Chief Executive Officer at People USA. His journey with that group started in 1999. It was inspired and driven by his personal lived experience. Steve has spent over 2 decades creating, providing, and promoting innovative crisis response services across the U.S. and internationally. These services provide our guests with person-centered communication, trauma-informed care, empathy, and positive expectations for their recovery, as well as their overall wellness. Steve's unique models and approaches significantly reduce hospital utilization, incarceration rates, and overall healthcare spending. And with that, I would like to turn it over to our first presenter, Dr. Watson.
So hi, everybody. It's great to be here. Let me see if I can get my slide moving. Just to give you an overview of what Steve and I will be talking about, I will cover just a little information about the components of pillars of the crisis care system and the involvement of peers in providing services across that continuum. I'm also going to talk a little bit about what states are doing to support peers as providers for crisis services. I'll talk a little bit about what research tells us about the benefits of making sure that we do have peers in the crisis care workforce, as well as I'm going to share a little bit of what we're learning in a NAMI-funded project that I'm working on with Michael Compton and Leah Pope that's looking at really what people want crisis responders to be able to do and what their core competencies should be, what their characteristics of services should look like. Steve, I'll pass it off to my colleague, Steve Miccio, and he'll talk about what the great work he's doing at People USA and their peer continuum of care. And he will also talk about the values that people with lived experience bring as service providers, as well as kind of talk about hiring peers and integrating them into the workforce. So I'll get started here. So many of you are likely familiar with the 3 pillars that SAMHSA has really identified as the components of a crisis care system, which are someone to talk to. So that could be call, chat, or text, but it could be a 988 call center that has that capability, someone to respond, which is typically a mobile crisis team, as well as a safe place to go. So some type of crisis receiving and stabilization facility. And we know that we have peers currently working across these pillars and doing great work. In terms of someone to talk to, we have peers working on peer-to-peer warm lines. We also have some alternative peer support crisis lines, such as the Wildflower Alliance crisis line and Trans Lifeline. And then, of course, we have peers that are working on 988 lines and other types of crisis lines. Peers are also working in the someone to respond pillar on mobile crisis teams. Many states are working to develop their mobile crisis teams consistent with SAMHSA guidelines, which are to include peers on those teams. So in many places, peers are on those teams. In some places, teams are made up completely of peers. Mobile crisis teams are typically accessed through a crisis line, through 988, through the mental health system side, and that's how they're dispatched. But we also see people with lived experience and certified peer providers working at some of the alternative response teams that are popping up across the country. And these are really teams that are typically 911 dispatched, and they tend to respond a little bit broader range of situations, but also inclusive of things that we would consider in terms of typically mental health or behavioral health crisis. We see many of the alternative response teams really prioritizing hiring people with lived experience because they're recognizing the value that they bring. Moving on to a safe place to go, peers are working in the various versions and of a safe place to go, from crisis stabilization and receiving facilities, respites, residential programs, living rooms. We've also seen some emergency departments. So in places that may not have a separate crisis stabilization facility, some emergency departments have incorporated peers to provide support for people that are receiving care there. And I was looking for some numbers just to see like what percentage of the peer provider workforce is working in crisis services. And the most recent that I could find was from 2016. And at that time, the estimate was that about 22% of people employed in peer provider positions were working in pre-crisis and crisis services. Given kind of the push to expand crisis services, as well as state and federal efforts to expand the role of peers in these services, my guess is that number may be a little bit higher at this time. So states are doing quite a bit to support peers becoming part of the crisis workforce, but there's a lot of variation in terms of kind of what's currently being done. Just like each state has its own Medicaid program. Some Medicaid programs cover the whole crisis continuum. Some Medicaid programs, there are states that don't cover mobile crisis. But what we're seeing is that in many states, they're working to include coverage of peer provided services in the crisis services that they're paying for. And for example, Minnesota's Medicaid program covers peer services throughout the entire crisis continuum. Michigan's a little bit different. They do cover peer services in crisis stabilization in residential settings. They don't yet cover it for mobile crisis, but they are actually working on making that change so that they're able to support and reimburse for peers that are working on mobile crisis teams. Again, Virginia covers post-crisis community stabilization services. There are some states that are requiring peers on their mobile crisis teams. In fiscal year 2022, 7 states required peers on their teams, and 13 more were planning to start doing that in 2023. And Illinois is one of those states that requires peers on their mobile crisis teams. And in order to develop that workforce so that there were certified peer providers in the workforce to hire for these teams, they actually use cannabis tax revenue funding to fund 11 institutions of higher education to provide peer support specialist training. And what was really interesting is that they provided funds to these schools to enroll students, and there's no tuition charge. Students get a stipend for the internship hours that they have to do to meet criteria to sit for the exam, assistance paying for taking the credentialing exam, and the schools receive funds as well to address any barriers that students may have in completing the program. That may include transportation, childcare, or assistance, legal assistance to get their record cleared so that they don't have barriers to employment once they complete the certification process. So there's a lot of work that's going on out there in the states. There's certainly recognition that peers are an important part of this workforce. And we're slowly kind of getting that financial reimbursement so that states are paying for the peers to be part of the workforce. The other thing is, some states are looking at having private insurers also provide some payment for those services. So there is some research that supports the benefits of having peers in the crisis services workforce. In terms of the someone to talk to, there's a study that looked at peer warm line services and found that those peer warm line was likely reducing emergency service use, and there's a missing word here, and increased community integration for people that utilize the peer warm line service. Similarly, so for peers working on mobile crisis teams, a more recent study actually found that having peers on mobile crisis teams helped people that they were supporting feel less alienated. And there was indications in the data that having peers on these teams may also reduce subsequent crisis and emergency service use by better connecting people and getting them stabilized with services. And interestingly, there's actually more research looking at peers working in a safe place to go in that pillar. There's a number of studies that are looking across peers working in emergency departments, crisis stabilization units, peer respites, living rooms. But across those, there's some really positive findings that suggest that having peers working in these services can reduce hospitalizations, use of emergency services, reducing costs, which is important to funders, and really they see fewer adverse experiences for the people that are seeking crisis support. Also, having peers involved can increase social connectedness and increase communication and collaboration. So again, overall, the research that's out there really supports that there are significant benefits for including peers as providers in the continuum of crisis care services. So now what I'd like to do is share a little bit about of what we're learning from a project that is being funded by NAMI National, and I'm working on with a couple of colleagues, Michael Compton and Leah Pope from Columbia University. And the overall goals of the project are to really look at what are the core values, skills, and competencies that are needed to provide crisis care. It's primarily focused on community response or mobile crisis response, but many of the people that we talked to, provided information about their experiences more broadly within the crisis service system. And one element of the study was focus groups with different stakeholders. In total, we did 13 stakeholder focus groups. 3 of them were with mobile crisis and community responder frontline staff, so people working on the front lines providing response. 7 of the focus groups were with adults with lived experience. 2 of those were with young adults, 18 to 25. And then 3 of the groups were with family members, because we wanted to get sort of multiple perspectives on really what should the characteristics and the skill sets of people responding to crisis be. And so we analyzed the transcripts from those focus groups for themes, looking at characteristics, values, and skills of that people wanted in crisis responders. We also looked at what helped people feel safe when they are experiencing a crisis, and what people thought qualifications should be. So starting with just the themes that came out in terms of the characteristics that people would like responders to have. Something that came out kind of across the board is that people providing crisis care and crisis support should be able to remain calm. They should be empathic and compassionate and genuine. We heard a lot of people talk about they wanted providers that really were doing the work for the right reason. There was a consistent theme across different components of this project beyond just the focus groups of the value of lived experience in providers as actually something that really helped them provide better support for people. We also looked at what values should kind of undergird crisis response and what values crisis responders should have. And people talked a lot about needing to be trauma informed, needing to be collaborative and non-hierarchical, so allowing people autonomy, allowing people choice, being really trustworthy and transparent as well. Again, they really wanted people that had a genuine sense of concern for others' well-being, and noted the value of lived experience. And what we did see, particularly when we talked to some of the people working on teams, is some of these teams, particularly the community responder teams, really prioritized hiring team members that had some type of lived experience, somewhat broadly defined, but not necessarily certified peer providers, but people with lived experience that they could bring to the work that they did. And they saw that as very valuable. And sometimes they were able to prioritize that over degrees for hiring people. So this is just a quote from someone from a community responder team that really kind of stressed the importance of having responders that have lived experience and have some experiences that they can draw on to really support the folks that they are responding to. We also asked people about the characteristics of care that help them feel safe when they're in a crisis. And again, the calmness piece came out again, and really having a responder that was empathic and attuned to basically paying attention to the person they were supporting. We heard people talk about they didn't find it very helpful when they had a responder that seemed a little bit more concerned about agency priorities or paperwork priorities than actually hearing what was going on with the person and understanding their needs. And that was something that came up in several focus groups. They wanted people that were trustworthy and honest, but they also, trust meant a couple of things. Trust also meant they wanted responders that trusted the person they're supporting to be the expert in their own experience. And that was really important to people. They also indicated they really wanted crisis services and crisis providers to pay attention to their comfort, that was something that was very helpful. And they indicated that they really also wanted some place to go that's not a hospital or a police station. So a a safe place to go, they really felt was something other than a hospital or a police station. So here's just another quote from one of the lived experience focus groups that really kind of highlighted that this is a person that had received support in a living room, and just highlighting how when they arrived there, people were paying attention and trying to make sure they were comfortable by offering water or hot chocolate. That it was a calm environment, and that the person that was providing support to them really listened, and instead of giving advice, used reflective listening skills. And it was actually a certified peer provider that they were talking about working with at that living room. So finally, I just want to kind of highlight, I think, what I've talked about in terms of what we know so far about the value of lived experience. And then what we've learned from the study, kind of, we didn't start the NAMI project just looking at peers as providers of crisis services, but what people told us was very consistent with the characteristics of peer-led services. And this is actually the cover of a publication that Aslan Center recently released, where they summarize kind of the characteristics of peer-led services. And you'll see here they're very consistent with the themes that came out of our the focus groups that we did, of what people are looking for in crisis services and what helps them feel safe and supported. So now I am going to hand things over to Steve Miccio, and he's going to talk about the really cool work that he's doing at People USA.
Thank you, Amy. Thanks for setting the stage for this and talking about, you know, those characteristics and things. I think as we look at the characteristics of what Amy had presented, we see what I see is there's the implicit trauma in the experience of so many people, and what they're looking for is not what tradition has always offered. And I think that's important to recognize. So I'm glad you're doing that work, Amy. It's really great. Hi, I'm Steve Miccio. I'm the CEO of People USA. Our old name used to be People Incorporated, and our previous name was Projects to Empower and Organize the Psychiatrically Labeled Incorporated, which really goes back to the mid 80s and early 90s, when a lot of folks were being discharged from large psychiatric centers in New York. And the New York State Office of Mental Health saw the value of peers back then and saw them as advocates, but also started to invest in communities for drop-in centers and advocacy groups to come together. And that's where we were born out of, was pure advocacy in the beginning, ensuring that the people that were being released from the hospitals were getting quality care. And it was very difficult because, as we know, and not enough of the dollars that came back in the community services was enough to really provide excellent care to the people. So having an advocacy organization was really important. And when I came to the organization in 1999, I learned a lot about the needs in advocacy that there were, you know, in our systems. And at that point, we were a very small organization. We were doing just primarily advocacy and support groups, and just trying to help people cope in community and get, you know, good housing, get good care and things like that. There was a lot of advocacy to do, but it wasn't, for me, it wasn't working as fast as I would like to see it go. I wasn't seeing the quality of care that people deserved, and I kept hearing the stories of the punitive care that they were receiving. And so one of my first, attempts at providing services was I got to put people with lived experience in a couple of emergency rooms in the Hudson Valley area of New York. And that was a great experience because I could train the staff and work with the staff to greet people in a more trauma-informed way, to welcome people to an emergency room, if you can imagine that, and to also offer a lot of information about what they were about to go through in that emergency room for a psychiatric evaluation, so that they weren't just sitting there in the dark. And the history, you know, my personal history was I was one of those people that entered an emergency room way back in the 90s and had to sit in a room with a security guard over me, not getting any information, not being told anything about what's about to happen, sitting there for quite a long time before a screener or doctor came in and interviewed me and decided I had bipolar disorder, and I was, you know, put up into the mental health unit. And then the first thing I walked into, and I remember this so clearly, was a little cup of medication that they wanted me to take and to get me on my, you know, what I call the road to recovery. And while in the hospital, no one ever mentioned recovery. No one ever mentioned hope. So the experience was traumatic for me. It was a learning experience at the same time, and I didn't want to let go of that. And over the years, as I recovered, I looked for the opportunity to make the system better, and I didn't know where to start. And I was very fortunate to find People Incorporated and get the job there, because now I felt that I could give back to the people in our community that weren't getting the quality care that they deserved. So that's where the services for us started, and then it just grew from there. And so, as you can see here in this slide, we really got into integrating our staff into all different types of services, not just the emergency room, but in the clinics and the partial hospitalizations and day treatments and things that existed back then, so that my staff could be greeting people and helping them navigate the care that they were getting in those service systems. So as you can imagine, back then in the peer world, I had to build a lot of strong relationships with traditional providers. And so most of my work was meeting with these providers to say, I think we can help you provide better care. And I would have to explain it and provide the concept of it. And very slowly, we started integrating our staff into those services, which I think was a great success. And it was just the beginning again for us. The other thing I did in the same, in the first 2 years there, was I designed and developed with, along with Sherry Mead as one of my subject matter experts and some other leaders in the field, respite houses. And so I designed it, I applied for it at the state of New York, and remarkably was funded for it. And that was my first dive into a true kind of a crisis respite place for people to go. And I designed it as a bed and breakfast filled with 24-hour, 7-day-a-week peer support, and people could stay 5 to 7 days. And the whole idea behind it was you can come in different levels and different stages of crisis, and we could work with you for those 7 days, providing peer support, providing education around other tools that are in the environment that they can use to prevent crisis in the future, but also to just give them a warm, comfortable, safe environment to stay in, so that they can gather their own thoughts and rest a little bit and think about themselves beyond their symptoms, but who they are as individuals. And if you ever see our houses, they have a lot of professional music instruments in them. They have professional art equipment in them, and they're just really lovely places to go, to relax and kind of, regroup. So that was the one of the bigger services that I started infusing, but the others were still embedding and having staff that were out in community and meeting people. So they were mobile. They weren't mobile teams at that time, but they were mobile staff that would go out and just meet people, build relationships, and help support them through advocacy, through support groups, through different ways and venues of giving people the support they need, through socialization. We call it nights out, but we had and still have these social events every week in all different areas of the counties that we serve in New York. And we provide those social opportunities for people to get away from the isolation, that they often live. We then started getting into supported housing, and I immediately embraced the Housing First model. And so we have over 140 apartments in different counties and communities where people can live with supports in housing permanently. And again, a very successful way of helping people and working with people. Then we moved into more crisis services. We're very involved in, and I didn't put that on here in the slide, but the criminal justice system as well. We do a lot of crisis intervention team training in our communities, but we also work in the jails and in the courts to help people divert from the criminal justice system. So we do a lot of that work in several counties and in different levels of service that we can help people kind of avoid or get away from the criminal justice system, which is really important for many people. Then we started diving into the mobile services, mobile teams, and we are a 100% peer-run organization, just so everyone can remember that and hears that. And our mobile teams are peer-run and peer-supported. And what I love about our teams is they respond with passion, compassion, empathy, and just focus on the engagement of getting the job done with the people that we're meeting in community. And we have teams in Yonkers, in White Plains, New York, in Glens Falls, New York, in Poughkeepsie, New York. So running various teams that are doing various things. Some are very embedded with police. Some are on the outskirts of working with police. My goal is to get them away from police eventually in this world so that we can evolve into a behavioral health care system that can kind of avoid the criminal justice world. But that's a work in progress, as we all know. And then I also got into designing and working on a crisis stabilization center. So I had been traveling all over the country, proudly touting the Rose houses, the respite houses to everyone, but looking at other crisis systems and services in other communities and what they were doing. And in Texas and New Hampshire and Denver, I saw some really neat things that I thought we could do in New York. And in working with our county, one of the counties, Dutchess County, New York, we were working on a plan of care for the community, a continuum of care, really, on how to serve the people in the community better. So it was from criminal justice to just regular traditional services, and how we could circumvent having to utilize the overburdened hospital system. And the Crisis Stabilization Center was something that I had designed for the community. And the county executive at that time liked the idea and went to the county legislation and got it funded so that we could actually open one. And we were the first, I don't know if we're the first, but we are a 100% peer-run crisis stabilization center with clinicians, with people that are recovery coaches for substance use, with peers, peer specialists, with case managers, care coordinators, and it's probably one of the most fun services I think we can operate, because we can welcome people into our services with a smile and say, we're glad you're here. It's completely voluntary. All of our services are, but provide them with the compassion that people, I think, deserve. And it's very different from walking into an emergency room or a crisis kind of a program that people would normally walk into. So those are just a few of the services. We have over 30 services that we provide now, but they're in all different various stages of specialty. And we've learned a lot just from opening one respite house. And that's been our experience, to learn and grow as we go, and to provide common sense approaches to common sense care. And that's where we work from. So, Amy was talking about the characteristics, but there was something that we found was a little deeper in what we were doing as an organization. And I kept asking, why is this working so well? And I kind of knew the answers, but I also still wanted to really dive into it and figure it out. And so we did as a team and as a community. And what we saw were these 4 pillars that really lent to our success and still do, today. And engagement wasn't just engagement as we think of. Many people can go to a clinic and go to the Medicaid or the window and provide their insurance card and told to sit down. But we are at the door when people come into our services or in community. We try to find, better engaging environments to engage people in, but we welcome people and we want to get to know people on a different level. We want to really avoid a traumatic engagement with people. So we have a very friendly approach to everyone we serve, whether it's the mobile teams, the stabilization, the respites, whatever it is. And that's a real important component to building a relationship from the beginning, building trust from the beginning. The next we said was environment. Environmentally, what are people walking into? What does it look like? What does it feel like? Can you feel the energy in the room, which is really about, for us, it's about recovery. And I'll talk about our philosophy in a minute. But we want it to be a comfortable environment. We want it to be a safe environment. And again, when you're on a mobile team, how do you create that safe environment? Well, Starbucks are pretty safe. They're pretty nice looking places. I mean, there's parks and there's different areas of our world that you can meet people and work with people in environments that can be much safer and less traumatic for many people, especially when they're dealing with crisis. I'll say philosophy next because you have to have a philosophy of recovery. And when I say a philosophy of recovery is you have to believe that people can do better. And when you have that attitude and that value and that philosophy of recovery being an expectation, it changes the dynamics of the relationship. And it changes the expectations of us as providers and of the people we serve. So believing and valuing recovery is a philosophy that is key to our success, and our staff, embrace that, philosophy of success there, which makes the difference between us and the people we serve. Then mutuality is the real secret sauce in all of this. And we're talking about peers, and that is one of the most powerful tools anyone can have if you have peers on your team. Being able to share your experience, being able to say to someone, you're not alone. And I've been through similar things, or you can start to share and have that communication. I know that when I was early in my recovery, that was one of the most powerful things that I felt when I went to a bipolar support group and heard people's stories and heard that I wasn't alone anymore. I was like, wow, this is powerful. I found self-determination, I found hope, and I felt empowered. And I started to look at myself differently and my recovery differently. So the mutuality really is the secret ingredient to all of this as we provide services in our communities. So I know that Amy talked about the characteristics and the values a little bit, and these are the values that we bring in our organization. And we did this through meeting with our staff, and we just did this recently. So we have about 150 staff, and we got together and we had values before this, and a lot of these are similar to the values we had before, but I think we're evolving. We're seeing what we need to really value to provide quality care and quality service for people so that they do feel safe. They have a safe place to call, a safe place to go. It's always really focused on engaging safely and listening with intent so that we can understand who it is we serve. So of course, hope is huge in all this. If people don't have hope, we can lend a vision of hope to people. And that's a wonderful thing. The authenticity is the integrity we bring to the work we believe in and the passion we have for the work we believe in. The courage is the courage for us to engage people that may not always be engaged in a more proactive way. And the staff are courageously sharing their story, their passion with the people we're serving in our communities. Again, mutuality, it's worth repeating because it is so important. And all of our staff in our organization, we never moved away from being an advocacy organization. We're still an advocacy organization and always will be, because people still need that advocacy to get the quality of care that they deserve in our communities. And so we will always be that advocate. The support, the support is not just support. The support is unending. Our follow-up with the people we serve is like no other. We serve people, we ask them if we can follow up. We'll do it within 24 hours. We'll do it within 48 hours. We'll do it within a week. We can build that level of support with people as they want it. And then we also have our 24-hour support warm lines that are open for them to call too. So the support is always there, whether it's the stabilization center, the respite house, or the support lines that we have, which is vital to when people know that there's someone that they can go to, someone they can call. Sometimes they don't go into that full-blown crisis, and it helps them get through it, knowing that it's just there. So that's so key and important in what we do. The honesty is we are honest with everyone we serve, and we are honest with ourselves. If it's beyond what we can handle or what we can do or how we can provide a service, we're going to be honest and say, well, that's not for us. We're going to find you the service that is for you and provide that for the people we serve. Compassion is so deep in our organization. When you talk to any of our staff, you can hear that passion and compassion that they have for the people in our communities, because they've lived it. They've lived a part of that or whatever. And they bring that with them every day to the job. The innovation, to me, is the innovation is the common sense approach to care. When you can provide compassion, empathy, empowerment, love in the work that you do, and the resiliency that we can offer, and we have for the people we serve, that's, some people call that innovation. We call it another day. I mean, but you have to be aware that, we know that our approach is a little different than traditional clinic services. So we embrace that innovation. We embrace looking for solutions every day in our communities as we continue to go forward and map them. Our community is so important. I always say, I know that the pure piece of quality care is not the panacea. It's not the answer, but it's a big part of it. But you need your community as well, because there are traditional services that work. There are non-traditional services that work for people. And when you can map and understand your community, you can usually find the tools that people need to promote their own recovery. And then the equity is the fairness and service that we deliver. There, a lot of organizations are working and doing DEI work. And if you don't have equity, if you don't have fairness, you can't provide across the board quality care for everybody, regardless of gender, color, background, whatever it is. That's infused into all of our services in the organization. So when we're hiring peers, when I first started hiring peers, if you said you had lived experience, I kind of hired you. And I didn't look for, a resume. I didn't look for the things that, people probably should look for. And I learned a valuable lesson from it. I hired some of the wrong people and I hired some of the right people. And this was a learning process for me, running a peer-run organization. But, we want peers to feel equal as team members. And what I mean by that is when you infuse peers into your traditional teams, if you have mobile teams or if you have crisis services or whatever services you have and you're hiring peers, it's not just good enough to say, oh, well, we hire peers. It's what do the peers do? But then going even deeper, when I worked with the Parachute Project in New York City, it was that infusion of peers into traditional services. And they were struggling, all the teams were struggling because they didn't have clear boundaries, policies. They didn't have the role clarification of everybody. So that's what we started designing and figuring out. We have to do these things so that people know what the psychiatrist does, what the family specialist does, what the care manager does, what the clinician does, what the peer does. And when you have that clarification, that begins to help all the teams work better together. They start to gel because they understand one another's roles. And as long as we stay within our lanes and work together, we have great teams that can work together. Building boundaries or understanding boundaries, the peer services have always had different boundaries. So we have to, when we're working with traditional services, you have to, work together on what those boundaries are. Supervision is so important. There's a lot of discussion around peer supervision. Should it be a peer supervising a peer? We believe it is. Some groups will say, well, no, we think clinicians should supervise peers. This is still a discussion around our country of how people are looking at supervision. But the way we do it is we supervise our staff, peers supervise peers. The workplace transformation and team building for success is so important because you want people to like where they work. And I've always said, I want us to be the Disneyland of behavioral health as an organization, because I want people to love what they do, but I want people that walk through our doors to love what we do too. And I want them to get a lot out of it, and have that opportunity for an amazing quality of life. So we now have required, goals for people that we hire, and lived experience, of course, is important. Work experience is required. And we can be a little flexible with that, but we really want people to understand some of the work norms that they're coming into. High school equivalency or higher is one of those requirements. The illustrating strength and wellness and recovery. So we ask in the interviews questions around, what are your values and what are your beliefs around recovery, and getting to know the individuals before we bring them on. Are they willing to share their experience, if they have disclosed? We do like it when people have stable housing, although I will tell you, over the 25 years that I've been here, we've had probably 10 people that we've hired that were not in any kind of stable housing, that once they were hired and had a job, they found that stable housing. So that's a case by case, and that's also a philosophy of leadership and how you want to run your organization, as you're hiring people. The positive philosophy towards wellness and recovery is important. Teamwork is always important. And I know that people have always gone through interviews and said, well, what are your ideas of teamwork? Or how do you feel about teamwork? And everyone will say, I'm a team player, until you hire them. And then you find out, oh, they're really not quite the team player that they thought they were. So again, and you look for salvageability after you hire people to see if you can train them. The excellent listening skills is so vital and important, but we train people on that too. We do a lot of training in the organization to help them understand how important listening is. Compassionate approach towards people, again, a part of our value system. And then the desirable stuff you can see on the side, that they have, the abilities to speak more than one language, hobbies, talents, resourceful knowledge of community services. We do like a mixed age group, and we have that in our organization now, a very mixed age group. Any volunteer experience they have is helpful and desired. Conflict resolution is great. Hands-on experience, sometimes, knowing how to fix things, because if you're working in a house and you're doing the overnight shift, you might be alone. And if you get a leak or you get a stuffed toilet or something, you might want somebody to have that skill, but it's not, essential that they have these kinds of skills. But these are the kinds of folks that we're trying to bring on board in the organization. So I could go on and on talking about the value of peers and what they've done, and I can talk about the value of infusing peers into what we've done in different workforce settings or work environments. And that's something we're also starting to track in our electronic health record system too, is not only are we infusing peer services into things, but what is the quality that we're bringing to it? What is the outcome of the individuals that we're serving? Are we improving quality of life? So if you're familiar with the 8 dimensions of wellness, that's something that we've, built a survey around to measure people's quality of life that they bring to, that we can bring to them, and that we can see a progression of recovery, and not just that we served someone, we referred someone or whatever. We want to make sure that we're following through and making sure that they get the quality of care and quality of services that they deserve. And so these are some of the references that have been put together and resources for you. And that's thank you. So I think that it's about time for questions.
All right. Thank you both so much. And you complemented each other. You know, Amy, I love that you started out sharing the research of why it works to have peer specialists involved in crisis services and what you learned in your research. And then Steve, you shared such a wonderful model of kind of how it was built from scratch and all the different components and the importance with peers woven throughout. So I'm supposed to ask you questions and not comment. Apologies, but I just enjoyed your presentations. So we did have a couple of questions from the audience, and more are starting to come in now. And I had a few questions as well as we started. So the first one, Dr. Watson, is for you. You shared the statistic that 2016, granted that was 8 years ago, but the research showed then that about 22% of the individuals in the peer workforce were working in crisis services. And the question I wrote immediately was, how come? You know, what are the barriers to making that higher? And then one of the participants wanted to know if that was actually a low stat based on the current. Do you consider that a low percentage based on the current environment?
Sure. And first, I just want to say I do research on the stuff that Steve already knows. But in terms of that question, I do think the 22% is probably a little bit low. But it also needs to be taken in the context of we have peers working in other parts of the behavioral health system, not just crisis. So, you know, just like, you know, some peers don't want to work in crisis services. That's not the fit that they have. And, or maybe they want to do it for a while and they need to move to working in another setting. So I think it's a little bit low. But I also think whether that's problematic, that whatever the number is, we have to really look at kind of, you know, how are people spread across different services. The other issue we have is that states are still catching up on actually paying for peers to be working in different crisis settings, which creates some issues. I know one of the, you know, some places have extra funding so they can pay for it outside of their Medicaid program, but that's not terribly common. So I think that's an issue. If we get that resolved more across the board, I think we'll see a higher percentage. But we also have to take into consideration that there's many other types of behavioral health settings that peers are working in and that we want them working in as well, because they're valuable across different service settings.
A related question, because I have so many, about how do we beat the drum and get more of them out there and involved in these roles. But again, it's not about me. Someone had asked the question in the chat and you responded to it, Dr. Watson, but I wanted to actually spotlight it in case people weren't following the chat, about de-escalation. What you learned in your research, and I'm curious, Steve, from you, what you've seen in your practice about the involvement of peers in de-escalation of crisis situations. Is that a concern? Is that something people worry about? Just curious what your research showed, and again, Steve, what you've seen happen.
For our research, I think a lot of the things that people with lived experience, people that are certified peer providers bring, make them natural de-escalators, because they meet someone and see the person. They bring authenticity, many things that help people feel like that it's safe for them to engage and kind of help them bring it down. So I think whether you use the term de-escalation what you actually mean that falls underneath de-escalation is what's important. And I think many of the things that end up getting listed in characteristics of peer services, characteristics of that peers bring, really make them natural de-escalators. And of course, there's some training that you can provide to help people sort of tighten up their skills and make them feel even more comfortable. But I think, again, people that can really connect with someone and make and help the person feel like it's safe, that they can trust enough to engage, that's going to help de-escalate someone faster than someone without any lived experience that's had lots of training coming in and trying to simulate that. People get it when the person that they're meeting really gets it.
Mm-hmm.
They notice.
Absolutely. Steve, what have you seen?
We've really seen that, first of all, the staff are trained a lot in de-escalation, and we even work with, we work with the state of New York. They have a whole de-escalation training. We created some of our own de-escalation training now that we have clinicians and working together as an organization, and understanding. I think the other part of this is understanding when somebody comes in and they're angry. And again, we're a voluntary service, but they're still going to come in. They're going to still have their issues or their traumas. They're going to be, kind of bubbling up or whatever. And when our staff don't react and they respond and they say, well, wow, what you're saying is really important right now. Can you tell me more about it? That's not the typical response they would get. They're usually say, well, no, you need to sit down and calm down, then we can talk. And that's not what we do. So there is training that has to go, around that. But then there is a lot of the folks that work for me have had that experience of being that person that was traumatized and upset, and they understand where that's coming from. And when you can share that and when you can offer that to people, that de-escalation happens very rapidly. And the other part of it too is that if it gets to that level, the staff can just say, look, the door's not locked from the inside. You can go. And that shifts the whole dynamic as well. When they're, oh, wait a minute, what do you mean I can go? It's so when people are empowered, and that's an empowering kind of a stance that we take, they start to think of it differently and they start to respond differently too.
And the person who put the question in just added that they were that's kind of the point they were making, that frequently people don't need de-escalation. They just need connection and the mutuality and the listening that you talked about, Steve, the listening that's just somebody actually hearing what they're saying. So I want to ask a clarifying question for both of you. Someone typed in that they wanted to confirm that the peers that we're speaking about today, that you're speaking about, are adults being peers to other adults. And they raise a really good question, because we get into this all the time at NAMI, because we have family members who are peers to other family members. And then we have, I want to say traditional peers, but some clarify the language, the jargon gets confusing for the world, but someone did ask to clarify what specifically you're both referring to today, which group?
Yes. So that's the answer. Yes. So here's what we're learning. And this is, I'm on a committee now in SAMHSA where we're looking at definitions, because there are so many different definitions of everything. And you're right. There's the family with the lived experience. There's the individual with lived experience. There's the youth with lived experience. There's the geriatric, just way too many definitions that are floating out there. And what we want to say is that, as a peer organization, we started out with just peers. We weren't family members. We weren't, we've expanded now to family members that have been traumatized because they've been trying to get loved ones help. And they understand it. They have this great, perception, and they're valuable. And then what I didn't talk about were the numbers in our services, but our stabilization center is across the lifespan. So we're serving youth and young kids all the way through the lifespan, and we're hiring younger staff now to address those youth. So we have all different age ranges of people with lived experience. And I think the challenge is the definitions, the defining what that really is. And that's something that I look forward to doing in the near future.
I look forward to seeing that too.
Yeah.
Interesting conversations. Amy, did you have thoughts or comments?
So the peers that what I was talking about, again, were generally adults with lived experience responding to people in crisis, or people that are seeking crisis services. So yeah, similar to Steve's.
Perfect. Thank you. Do either of you, again, feel free, either one of you, to respond or both respond, because there's a follow-up question in here. What do you think about family members providing support to individuals, and individuals providing individuals with mental health conditions providing support to families, vice versa? Again, another question we get at NAMI frequently. You have support groups for families, support groups for individuals. Should you mix support groups?
That's something that's evolving, because I know that when I started in this industry, NAMI was the enemy because they were family members. They weren't people with lived experience. Right. And that was I used to go to the most volatile peer support or
I
peer
was at
groups.
some of those, yeah.
Yeah. So, but again, what we're seeing, and again, a common sense approach to good care, is that there are some family members that can certainly meet with people with lived experience, with peers, and have a great outcome, great, relationship. And then there are people that say, no, I just want to talk to somebody with lived experience that has been through this, what I'm going through. So when you empower people and you offer the choice and you create that menu of service for people, they get to choose what they want. We don't have to dictate what we think they want. It's their choice. So, and again, that becomes empowerment, which becomes, part of their recovery. It really enhances it.
Exactly. Amy, your thoughts?
Just thinking about, many of us are both.
Yeah.
So, and I think that's important to consider too. The older we get, the more likely that we have multiple perspectives.
We talk about that frequently here as well. I have to remember which hat I'm wearing. Am I wearing the hat of someone who's dealt with depression my whole life, or am I wearing the hat of a family member, or am I wearing the hat of what I refer to as a recovering mental health professional, or as an advocate? We do have to think about it. And Steve, I think you nailed it. At the end of the day, it's about choice. What is the person more comfortable with? And just having the choice is so empowering. Someone put a question in earlier about asking to have it explained. What's the difference when you're talking about someone with lived experience and a peer?
And definitions, right? So when I first started, we were called ex-patients, just 25 years ago, or what was the other? Consumers. There was all these different terms were out there, right? Time evolved, so then we became peers, and people still use that quite a bit because they are now certified as peer specialists, which means they are people with lived experience. And what lived experience means, and that's where it gets a little murky, because lived experience could be police officers have lived experience, right? But that's in their organization. All different groups have lived experience, but lived experience, and when we say it here, are people with substance or mental health experience in the systems, or maybe not in the systems, but have that experience of life.
I also think about it when people then identify as a peer, moving into peer and being a peer provider. So you could have lived experience and not choose to identify as a peer, or become a peer provider. So I think the lived experience is a bigger umbrella, and then people kind of figure out where they want to live under that umbrella.
That's a good way to describe it. And then you add the other complication of credentialing and what that looks like, which is a whole other webinar or 2 or 10 down the road. So we won't go there right now. I'm curious about what trends you've both seen, and you both alluded to this in different ways, but what trends you've seen in the time that you've been involved in this space, either as someone in the movement, Steve, or someone researching it, studying it, Amy, about there's certainly an increase in recognition of the importance of peer support specialists. There's a becoming more of an acceptance in the professional world, if you will. We talked about payers. Several of you have mentioned the other things. What trends have you noticed in terms of barriers that have been in the way of that happening, and maybe changes you've seen in those barriers being lessened or being addressed? And someone asked during, maybe Steve, it was when you were presenting, somebody said, what are you talking about barriers? What kind of barriers? So wanted to hear a little bit about what trends you've observed, as much as anything to give people on the call hope. Change is possible. Sometimes
Yeah.
it's slow, but just would
Yeah.
love to hear both your perspectives.
Sure. Just from my perspective, when I first opened the first respite house, I was sitting in a provider meeting and the hospital representatives were there, and I was explaining it, and they got a bit offended in some way. I don't know why, and literally said, "You mean you're going to close our hospital?" And I said, "I got a 4-bedroom house. You have a 40-bed, inpatient unit. No, I don't think I'm going to, I think I'm going to help alleviate some of the clutter that you might have at the hospital." But we're talking about stigma, we're talking about discrimination, we're talking about fear. And that's, that is still there, unfortunately. And I had to work really hard with my organization and building our integrity and showing outcomes that were excellent for the most part before the traditional service system started to embrace it. And what I notice is that when people come and visit us, from whether you're a psychiatrist, whoever you are, doesn't matter. When they come and visit, they go through the house or they go through the stabilization center, and it's an aha moment for them. It's like, oh, now I see what you're doing here, because they get to meet the staff, they get to meet the guests sometimes and talk to them and get their perspectives and things like that. So the trend is that it's moving towards, more peer involvement and recognition and acceptance, but we still have a lot of work to do, because there's still groups that I get calls all the time that say, how do you hire peers? How do you put them in your services? What do you do? Where do you start? And again, it's, to me, it's a common sense approach. You start with their skill set. You start with how they can help you and your organization serve people better. But that's easier said than done for many people. But the hope is there that, as we're working with SAMHSA and the Spark group, in SAMHSA, that we're defining this, we're putting, values to it, we're putting roles to it, and moving forward to help others, to educate others in the country how they can be successful infusing peers into their services.
And I think, one of the barriers that we see right now is just, being able to pay for peers. And we're seeing movement there. We're seeing a lot of movement there. Some of it's coming from just the fact that we have such huge workforce shortages in terms of more traditional behavioral health workforce. So peers are seen as the answer. I think many of the forces aren't necessarily, some are recognizing the value of peers, some are just saying we need people. But that could benefit the folks that are receiving services if we can move more peers in. So I think the funding is an issue. I think we need to get funding at a level where peers not only that can be paid, but they can be paid a living wage. We shouldn't look at peers as just a way to save money in the workforce, because we should look at what it is they're providing. So I think that's something, and I think there's more movement to do that more broadly, is looking at what skills and competencies people bring to jobs and paying them for that instead of putting in barriers of degrees and those types of things. So I think that's a broader sort of workforce movement, not just in the behavioral health workforce. And I think that's going to benefit this effort too, that we can look at if are people doing the work that we really need done, and they're doing it really well and probably better than maybe other parts of the workforce are doing it, then we should be able to justify paying them for it. So I see a lot of hope. I really do. And I also think, I mean, one of the things that I've bumped into is such dissatisfaction with some traditional services. And, you know, I've worked at a school of social work for a very long time, but sometimes the way we train social work clinicians is we train out of them some of that compassion as well. So, you know, we have to train them so they can pass the test on the DSM, but we give them that lens as opposed to the lens they may have walked in the doors with of let's go meet people where they're at and see how we can support them. So there are discussions, at least some of my social work colleagues of talking about how do we look at that as well. But so I think there's a number of forces going on right now that give me a lot of hope that we will be able to pay for and support more peers in the workforce and also make it the workforce someplace they want to stay, where they feel valued and actually recognized for what they bring.
So many highlightable points that you made. You know, it's not just payment, it's paying a living wage. And it's not just saving money, it's acknowledging the genuine benefit and the enhancement to recovery when you involve peers. So again, so many gold nuggets, and folks in the chat are agreeing. One of the things that this is a Terry question. One of the things we hear frequently in conversations about peer support specialist certification, the model standards came out from SAMHSA last year, looking at what do those do, you know, what else needs to be done, how do we support it, etc. Steve, I was curious as you were talking about I loved your comment that peers supervise peers, others supervise others, but what about support for peer support specialists? You know, how do you address that, Steve, in People USA? And Amy, what have you heard about that in your research? Even if I'm interested in doing this work is stressful for all of us. How do we support each other? And especially when you're talking about a peer workforce.
Yeah. We have a tremendous support system within the organization. We designed and developed a wellness committee, and it's made up of all staff of all different levels in the organization to talk about this, because we do see people at times have challenges, and their performance, you know, is challenged. Their world is challenged sometimes, and many organizations, I think, would look at that individual and say, well, you know, we're gonna have to let you go because you can't perform. And what we do is we say, well, if you're open to it, we'd love to support you. We'd love to see how we can help you get through this. And we've had many situations and circumstances where people have had challenges and have bounced back and come back stronger because and people have said so many times to me on a private, you know, in a private email or personally, and said, I can't believe how you supported me, because the last time this happened to me, I lost my job, I lost everything. And I said, well, that's why we support you, because we know, we understand, and we're resilient enough that we can work with you and get you back to, you know, not even baseline, better than baseline, you know, better, you know, and a better quality of life for yourselves. So, and our wellness committee does a million different things. There's always something going on, you know, and it's fun because I'm not that kind of a celebratory kind of guy, but the staff are, and you name it, from birthdays to just what to wear that day. And you see all the staff come in in their people garb, or they come in whatever, you know, they chose to do. But then also offering one another kudos, you know, saw you doing this the other day. That was amazing. And it could be any level of anyone doing that. And so this is really a nice place to work because people support one another so much, and it helps us get through the tough days.
Mhm. Amy, anything you've seen or have come across in addition to what Steve shared?
I think what Steve's organization is doing should be duplicated in many
So do
places.
I.
One thing that I have noted, so I have an evaluation role on the CRSS Success Program in Illinois that's funding the 11 schools to run programs. And the schools have done a really nice job kind of bringing in cohorts that become very cohesive, and they become sort of a group that sticks together through the program, but beyond as well. So there's been some really interesting things, and that's why I really worry there's some places that are pushing to try to be able to do programs entirely online, and that's not allowable in Illinois. I do think having that component where people get to meet each other and have some face-to-face time, but that's sort of a naturally thing that seems to be cultivated by the way these programs are designed. And I think it'll help many of the folks that are going through the programs throughout their careers, because they're developing that support system of other peer support providers. But yes, agencies absolutely have a responsibility to do this as well. And if they would all actually copy Steve's agency, probably they'd do a much better job retaining their staff and keeping them healthy.
Practice what we preach, right? I mean, that makes so much sense. Someone had typed in the chat, and I'm saying this for anyone who's listening and not following the chat, had asked about the work group that Steve mentioned and where you could learn more about that. And one of the other participants put an email address in here for John Palmieri to email to get more information. So I wanted to call people's attention to that. And also someone had mentioned getting access to the quality of life survey that one of you mentioned. So I don't know if there's a link that you can.
There is not, but if I can get it to someone on this, the team here, I can get them connected to it.
Perfect.
Yeah.
And you can feel free, Steve, to email that to us here at NAMI or to Kelly at NASHPD, and we'll get that out.
Great.
And I think we've addressed all the questions, but just to give folks another minute if they want to type something in, any closing comments from either of you that you wanted to mention but didn't mention, or calls to action? Because again, I always wonder when we get the choir on these calls, you know, what do we all need to be doing? How do we keep the momentum going? Because I agree with both of you. I've seen more growth in the last probably 2 years than in the previous 20. Not that I've been around that long, but you know, I've read. So what thoughts from both of you? What can we do?
You know, I would say if you've seen one state, you've seen one state. If you've seen one county, you've seen one. Everyone always says that, right? And it's kind of true. I mean, that's the way it is. But advocacy is advocacy, and asking for the right things is important, and having the right questions ready, you know, as you're advocating are important. So I think this is, you know, we need to have, this is a human rights movement. It really is. And I think we need to all be going in the same direction to say, you know, we want peers because we know it can improve our quality of care. It can improve our system. It can make everyone's life easier, better. So we're talking about not just providing the service. What are you going to get from this service? And we need to teach, you know, the legislators and the powers that be that there is value in not just having peers and integration and all that going on. There's value to our world in doing this. So that's the way I leave it. I think everyone needs to become advocates and help us support this.
I completely agree with Steve. I also recommend that people push their local agencies that if they don't hire peers, or if they do, either way, to do site visits out by Steve, and to see what they're doing at his agency. Because I do think there's a lot that agencies, maybe they just don't know. or maybe they haven't been able to figure out how to do. So looking at good examples of how to hire peers and really integrate them into their services, I think is going to be really important.
And continuing to put spotlights on those organizations, which show that it's not just possible, it's and you use the word common sense several times, Steve. Again, some of this is not rocket science. It's treating people like people and meeting them where they are. Thank you so much, Amy and Steve. And Kelly, how would you like to close up? And also huge thanks to our interpreters, to Joy and to Daniel. That's a tremendous benefit of these webinars.
Absolutely.
Go ahead, Bailey.
Thank you so much for this wonderful information. This does conclude today's session, and you may now disconnect.